Good morning, everybody. So I would like to thank the scientific committee for giving the opportunity to conduct an IC in this prestigious All India Ophthalmological Society conference. The topic which we would be taking up today is understanding the dynamics of iris in phacoemulsification surgery. So this would include the phacoemulsification surgery, wherein we have all the problems related to iris and the sequelae involved in it, wherein I would be taking up intraoperative floppy iris syndrome and fluid misdirection syndrome. Dr. Amar Agarwal would be taking up iris repair. Answers to small pupil would be taken by none other than Dr. Suvain. And iris prolapse, what next? We have dedicated full 12 minutes to it. What are the etiopathogenesis and everything involved in it? So let's get things going. So I would be talking about intraoperative floppy iris syndrome. Well, we should know what are the causes of iris prolapsing. It could be a positive pressure, which Dr. Tushya would be dealing. Procedural causes, he would be dealing. I would be dealing with iris challenges as far as floppy iris is concerned. That is primarily because of alpha-1 adrenergic blockage, but it can be there because of atrophic iris, chronic use of pilocar, and pseudoexfoliation syndrome. So let's see what happens. Whenever any patient who is getting treated for BPH is using tamsulosin or any other alpha adrenergic receptor blocking agent, specifically more the alpha-1 adrenergic receptors, which are in the form of tamsulosin. So it blocks the dilator muscle of iris. So what happens when the dilator muscle of iris gets blocked? There is a predisposition to reduce maximum pupillary diameter. Why? Because there is a dilatation of the dilator muscle of iris. And what happens whenever we use it for a long time? There's a prolonged blockage causes disuse atrophy and thinning of the dilator muscles. So what happens is that there's a reduced maximum pupillary size. That is the first thing which is there. The second thing is, let's understand what happens to the iris structure. Well, the iris structure gets changed because of blockage, disuse, and the dilator muscle region, as you will find it here, becomes thinned out and atrophic. So what happens whenever there is a fluid influx? So whenever there is an excess of fluid to the posterior aspect of the iris, because of the thinned out iris in this half, there is increased billowing. So mark my words, there is going to be increased billowing in response to the fluidics in the anterior chamber. So let's understand the dynamics in iris trauma in normal patients. So what happens is, there's a strong dilated tone, so pupil dilated with maximum dilatation. So whenever there is an iris touch, the trauma causes minimum pupillary constriction because of the fact that the dilator muscle is stronger. So whenever there is a repeated touch, as you would find now, it will constrict slightly because the dilator tone is still stronger than the constrictor tone. And whenever there is a repeated, so that there the constrictor muscle overpowers and we have pupillary constriction. So this is what the basic phenomenon is. And how different is it when the patient is using alpha-1 antagonist drug? So there's an exaggerated response to iris touch. So here what you will find is that there is a weak dilator muscle tone action. A small touch causes pupillary constriction. So this is the difference. So IFIS has iris billowing, fluttering, progressive pupillary constriction, and tendency of iris to prolapse. As you will see, there is iris billowing, constrictive, progressive pupillary constriction, and iris prolapsing through the incisions. So there's a good incidence of floppy iris or prolapse in patients who are using these drugs. So what are the preoperative challenges and the intraoperative challenges? I'll talk about the preoperative challenges first. It takes a longer dilatation time for the pupil to dilate. You have to mark who the patients who are using tamsulosin, and you have to give them adequate time for the pupil to dilate. So what are the pre-operative pharmacomydriasis which we have to use? Parasympatholytics, because they have an indirect action by inhibiting iris constrictor muscles in the form of atropine, cyclopentolate, or tropicamide. Sympathomimetics, they act in cohesion with parasympatholytic because they have a direct action by displacing tamsulosin and increasing iris tone. However, it is inefficient when the atrophy of the muscle occurs. It is only more efficient when the blockage is there. It can be used in the form of epinephrine or phenylephrine, and non-steroidal have their action, as everybody is aware of. So what is the predictive test for risk for intraoperative floppy iris syndrome in patients who are using alpha-1 antagonist drugs? Any pupil who's around 7 or less than 7 is predisposed. So that is something which we need to understand. And what is the use of Malignant and the Suvain B-hex ring in intraoperative floppy iris syndrome? Well, no doubt it maintains 6 millimeter pupil. But the most important thing which you have to bear in mind is that there is still IFIS in 93% patients. So no doubt there is no significant intraoperative or postoperative complication. So what we have to realize that no doubt we can use these intraoperative pupillary expansion devices, but we should know what the technique is. So the technique.
This video is a stepwise approach in a blue iris patient on tamsulosin for more than 15 years with maximum pupillary dilatation of 4.2 millimeter. Preoperatively, the pupil needs to be given adequate time to dilate. A micro incision with a long anterior tunnel parallel to the iris is given. A short tunnel can predispose to iris prolapse. A calibrated side port incision with a 25 gauge needle is made. This provides additional anterior chamber stability, atraumatic surgery, and minimal fluid access to posterior surface of iris. 25 gauge needle creates 500 micron diameter incision. The shaft of the chopper is fashioned between 400 to 450 micron from the distal to the proximal part. This provides adequate sinking in shape and size, allowing easy manipulation in interior chamber. The long, thin tunneled incision decreases predisposition to iris touch and frequently makes the incision self-sealing. There is no change in pupil size and no excess of fluid to posterior aspect of iris, thereby minimizing the chances of billowing and progression of IFIS. Non-calibrated side port incision causes IFIS with disproportionate efflux of fluid, unstable interior chamber, excess of fluid to posterior aspect of iris, and iris prolapse. Intracameral epinephrine is used to dilate the pupil. Epinephrine is more effective in early stage when receptors are blocked. However, in this advanced case, due to muscle atrophy, there is less mydriasis. In dilated pupil size less than 4.5 mm, a dilating aid can be easily used. In this case, viscodispersive OVD is injected over the subincisional iris, followed by injection in the remaining part. Urshanov's dry soft shell technique for OVDs includes using viscodispersive over the iris, viscocohesive in the pupillary area with PSS below the viscocohesive with use of low parameters. OVD injection has to be guarded as overinflation can cause iris prolapse. Capsulorhexis is done with forceps through micro incision. The plane of the forceps is kept close to the capsule for control. Cystitome also helps with enhanced chamber stability. Slow hydrodissection is done as vigorous hydrodissection can cause iris prolapse. Low fluid parameters are used. Low IOP nuclear emulsification is carried out to provide stable chamber settings. continuous irrigation is not used. The irrigation is stopped and then the tip taken out. Keeping irrigation on while removal of tips predisposes to iris prolapse and IFIS. Nuclear chopping of grade 2 to 3 nuclear sclerosis is done using selective use of vacuum at deeper plane to allow firm gripping of nucleus. The aim is to chop into small nuclear fragments with total separation. The separated nuclear fragments are left in situ till we achieve totally separated nuclear fragments. This helps in providing stable interior chamber and capsular bag and decreased excess of fluid to posterior aspect of iris. Firmly gripped hard nuclear fragments are brought at the level of interior capsule. Nuclear emulsification of the hard fragments require higher fluidics. The emulsification is done in the center and in the proximal half of the pupil to avoid inadvertent emulsification of iris. The central position helps in avoiding aspiration of viscodispersive OVD used in this case. Irrigation and aspiration is done using a curved coaxial tip with sleeve highly retracted to separate the plane of irrigation and aspiration. The vacuum is not increased below the iris to avoid inadvertent trauma to the iris. The vacuum is increased after fixing the cortex and bringing it in the center, and the tip is not angled downwards. Bimanual irrigation and aspiration can be the preferred technique depending on the surgeon's choice. The separation of plane of irrigation and aspiration helps in stabilizing the interior chamber and preventing excess of fluid to posterior aspect of iris.
So decoding, we should know the technique. It has to be an atraumatic surgery. Use sympathomimetics to your advantage. That's a very important part which we have to realize. Using intracameral adrenaline, epinephrine as and when required. Viscomydriasis. Decrease excess of fluid to posterior iris aspect. Calibrated side port incision. Well, side port incision is like an, an adopted child. We are not looking after that. So that has to be looked after, because calibrated side port incision, if we don't take care, that causes the efflux of fluid and that precipitates IFIS. So low IOP phaco is also very important. Summarizing, no predisposition in patients using alpha antagonist drugs. Your whole staff should be aware of that. Use pupillary dilating aids to your advantage. Most importantly, know the techniques. Thank you very much. So next would be Dr. Amar Agarwal, who would be taking up iris repair. In the meantime, intraoperative floppy iris syndrome is something. Yeah. How many of you are calibrating your side port incision? Or is it just that when I say calibrated side port incision, what I mean is your side port incision and your side port chopper. There should not be a disagreement between them. Because if there is a disagreement, because I personally feel that if you have to, you have to respect tissues to get the required results. I would suggest that everybody who does surgery should see what the pupil size is when the surgery starts and when the surgery ends. And if by any means you find that the pupil size has decreased, you have to know the reason. This means you have touched the iris and created problems.